Hello everyone and welcome to our third 3D system webinar. My name is Tal Aziz, a Senior Product Manager for the ANGIO Mentor line of products, and I'm happy to be your moderator for today's webinar. In today's webinar, our speaker, Dr. Zoran Rancic, will discuss endovascular treatment of ruptured AAA and how team training is practiced in this scenario. On the second part of the webinar, will be dedicated to showing you an example of ruptured AAA treatment case using the ANGIO Mentor Suite simulator. And at the end of the session, we will have time to answer some of your questions. If there will be any questions that will not be answered during the webinar, we will reply them in email at the end of the session. Now, a short explanation of how to participate in the webinar. So on your right-hand side of the screen, you have a box where you can type and send your question during the webinar. And also during the webinar, we will ask 4 questions. So please answer by clicking the relevant answer on your screen. Few tips to improve the user experience from this webinar. So first of all, close all open windows on your desktop and click on the full screen button when watching the video on the second part of the webinar to achieve the best quality. A few words to introduce you to 3D System Healthcare Division. So today we are on the front line of surgical planning and personalized medical solutions, with a clear vision of providing 3D printed tools for enhanced clinical procedure performance. Our ANGIO Mentor virtual reality simulator is used for the purpose of training and preoperative planning of endovascular procedures, with support for more than 25 procedures now for individual and team training and over 300 cases, used for training of multiple disciplines. So at this point, we would like to ask you the first poll question. If you can please specify your specialty: vascular surgery, general surgery, interventional radiology, or other. So, if you can see the results on the screen, you will see that some of you are vascular surgeons, but most of you are coming from other areas, so probably I hope you will find this webinar interesting for you. So now I'm honored to present our guest speaker, Dr. Zoran Rancic. He's an associate professor of vascular surgery at the University Hospital of Zurich in Switzerland, with experience of more than 35 endovascular procedures of ruptured AAA treatment, a course director for ESVS Aortic Rupture course, and an organizer of ruptured AAA team training in Medtronic Academia. Dr. Rancic, please, you can take it from here.
Hello, everybody. Good evening, good afternoon, or good morning. It depends on where you are coming from and how you are logged in. Thank you, Tal, for a nice introduction. So I don't have anything to disclose of any financial interest for this presentation, and I would like to ask you, how is the abdominal aortic rupture treated in your hospital? So because you're a lot of vascular surgeon, I'd expect to see the answer, but I would be happy to see that. Please vote. So mostly open, equally open and endovascular, and mostly endovascular. So I think it's really interesting because those who are answered equally open and endovascular, they have the real good opportunity to offer to the people the best treatment and to do it tailored to the exact case, which can depends on the anatomy and the clinical comorbidities in the patient. So just to mention to someone, if someone is not a doctor, what does it mean, aneurysm? Aneurysm, it means irreversible dilatation of aorta, of any arteria, in this case infrarenal aorta. And the main risk of the AAA is the rupture. And if the rupture occurs, the blood is going outside of the aorta wall and then can be stay in the retroperitoneum. Then we say it's about contained retroperitoneal rupture. If the blood is among the bowels, intraperitoneal cavity, then it is intraperitoneal rupture, but also could happen that there is communication between the aortic wall and the bowel when we are saying it's a aortoduodenal or aortoenteric fistula. The presentation, the most frequent, is presented with pain syncope in patients with known abdominal aneurysm, but mostly the rupture is coming without any signs. That means the people does not aware that they have aneurysm and it presents with a rupture. And this is a great mimic. It looks like ureteral stone, it looks like diverculitis, it looks like myocardial ischemia. In the mid of 50s years, a vascular surgeon started to treat the patients with ruptured aneurysm, but the first endovascular treatment was made in 1994, and this did Frank Witt in Montefiore Hospital. In courtesy of him, I have this slide I'm presenting to you. It is unoperable patient with hostile abdomen, with severe ill, with blood pressure 60 millimeters mercury. It was the first case treated, but Montefiore sten graf un autounilia can fem crossover. We started in Zurich to do the endovascular treatment of ruptured AAA in 1997, and since then we developed one integrated logistics system for endovascular treatment, and this system has some components. These components are pre-hospital, are in-hospital, and are out post-hospital. Important components of these systems are to have one integrated system how to treat. So for us was very important to define, and it was defined in a group of Professor Lasha. This is logistics. Start with standard operating procedure. That means in any case we have a suspected acute aortic lesion, the first what we are doing, we are telling to the referred people that we have to lower blood pressure. Lowering the blood pressure, we have time to perform the CT scan. CT scan is going to, CT angio will help us to define if the lesion is acute aortic rupture, thoracoabdominal rupture, complicated, for example, B dissection, or it is just symptomatic abdominal, symptomatic thoracal, or uncomplicated B dissection. That means CT is a core for the diagnosis. There, if it is acute rupture or complicated B dissection, we are doing the emergent therapy. If it is symptomatic, we are proceed with medical treatment. That means beta blockers. We are going to close surveillance, repeat CT scan. It depends on the CT scan. We will, on the follow-up, we will decide either to operate or to continue with best medical treatment. What to do in case pre-hospital? That means in Switzerland, in my university hospital, the people are referred, almost all people are referred to our hospital. That means by phone, the general practitioners, doctors, other hospitals are calling us and telling us we have a patient with a suspected or we have a patient with diagnosed ruptured AAA. To do this, we have to have logistic. We have to have hospital. We have to have teams. In our team are interventional radiologists, vascular surgeons, angiologists, anesthesiologists, also the scrub nurses, a lot of technicians. But also we have to be available 24 hours per day, 7 days a week. At the moment we get a call, and when the patient is going to our hospital, all the involved partners, all the potential team members have to be involved. From the operating theater, information desk, that we have to prepare our set in case to put a balloon in the shock room. The first what we have to take care in the patient with suspected rupture is management of blood pressure. That means they are involved and they're integrated two principles. The first principle is permissive hypotension and hypotensive hemostasis. That means if the patient has a normal or high blood pressure, we are going to use a medication to lower the blood pressure with our goal to have systolic blood pressure of below 90 millimeters mercury. In case that the patient have a low blood pressure and it's stable, we are just going to restrict the fluid with a with a target of blood pressure of 70, and the patient we have to talk to the patient to be sure if the patient is conscious. If the patient is unstable, then we are going to give catecholamines or fluids, but we have to take care and to have into consideration all the blood we are going through the fluid, through the rupture site is going to retroperitoneal and could cause abdominal compartment syndrome. So this is our algorithm, what is going in case of aortic emergency. Patient is coming to the shock room, to the emergency room. Then we are going to the CT scan in order to prove feasibility. Are we going to take open or surgery of endovascular surgery? After obtaining the CT scan, patient is coming back in the shock room. Then anesthetic workup is continuing, and vascular surgeon and interventional radiologists will decide how to proceed and which procedure to proceed. Open repair when we are going to the operating theater, or even when we are going to angio suite or hybrid room that we have in our hospital. After the procedure, we are going to perform a new CT angio to see should we correct something or the patient is going to go to the ICU. For our protocol, it's very important that we define all the algorithms for every step which is a part of the standard operating procedure. That means we have clearly defined what could happen in the shock room. That means we are going to control the blood pressure in the shock room. This is our shock room with esmolol, very short-acting beta blocker, or using nitroglycerin. We are going to make light sedation with remifentanil, and there we are going to do just very simple quick check of the patient close to our shock room. As you can see here through this glass window is our CT scan. That means the patient, after very quick check up, is going to go to the CT scan. Also, we define everything what is going to do. We define protocol, we are defining which CT examination should be done, and we are doing always CT angiography with 3 phases, native, arterial, and venous, and we are always doing thoraco-abdominal, giving us to have a diagnosis, proper diagnosis, because it might be not a rupture, that could be dissection, and to make a possibility to plan the procedure. Then when the CT is finished, then we are examining if the patient is feasible for the open and endovascular treatment. And for us, only anatomy is decision making. Of course, we don't treat every patient, except we treat all the patients who are coming to our hospital, except the patients with preoperative ongoing heart message more than 30 minutes, Alzheimer's disease or known end stage disease. When the patient is coming to the hospital, patient could crash, and then we can put balloon, aortic balloon. This is aortic balloon, which is some technical, we have several technical details how to use it good, and this could be placed at any time during the cycle when the patient is coming into hospital. So hemodynamic instability that occur during the hospital after admission in the hospital is for us not at exclusion criteria to treat a patient with emergent EVAR. In general, we are using almost 20% of our patients need balloon, aortic balloon. We can put a balloon from transfemoral, percutaneously transfemoral, or in this case, we can put it from axillary artery. This is one of the reasons what we are using thoraco-abdominal CT angiography. As you can see, before the balloon, the systolic blood pressure 35 after inserting a balloon and inflating balloon. Supraceliac, we have increase of blood pressure of 85, and we maintain the stability of the patient. As I showed you, this is our shock room. This is CT is on this side, and over the corridor is our operating room. That means the distance between the diagnosis, emergent CT angio and operating room is very short. For us, treatment of ruptured AAA is the same as the treatment of an elective AAA. That means we are doing almost 82% of people in local anesthesia with analgesic sedation, and only in case that the patient is very aggressive or moving a lot, then we have, or deteriorated, we have to intubate patient, and then we are proceeding with general anesthesia. But in 70% we are completing and finishing with LR with analgesic sedation. The type of prosthesis we are using, in general, we are using infrarenal and transrenal fixation, and we are using bifurcated stent graft, depending on some clinics. In some clinics, they're using ortho-uni-iliac with fem-fem crossover. In general, we can use those which are we using in our normal elective EVAR. And also, what I point in here as adjuncts, that means in case when the proximal landing zone of the stent graft could not be infrarenal, or not, it's so hostile neck or shaggy neck at the level of the renal artery where we could not put transrenal fixation prosthesis, we are extending the proximal landing zone above the renal arteries, sometimes above the mesenteric arteries, using the parallel grafts. It's known as endo debranching, or using a chimney and parallel stent grafts. The main killer in patients with ruptured AAA is abdominal compartment syndrome, and we have to be aware of that at the beginning of our treatment, of our management of patients with a rupture. Because if we think we finish the treatment of the patient, we put in the stent graft and it's finished. No, it's not finished. We have to take close surveillance, and we have to measure intra-abdominal blood pressure through the catheter into bladder, and we have to see how it is. So abdominal compartment syndrome, according to the World Association of Compartment Syndrome, is defined as pressure above 20 millimeters mercury and new organ dysfunctional failure. We are measuring that in all patients. The first measurement is in the shock room and thereafter after the procedure. The importance of this is, you can see here how it looks like. Mortality in patients with emergent EVAR in the patients without abdominal compartment syndrome, it's 9%. If abdominal compartment syndrome occurs, then the mortality is 28%. This is also our study for 1997 to 2002, when you can see in the case when we close the abdomen, this is open surgery, all the patients developed the compartment, and if they developed compartment, they were dead. That means after that we developed in the cases when the rupture is treated by open surgery, we always leave abdomen open. We never close the abdomen. After stabilization of the patients on the day 2nd, on the day 3rd, we will go to close the abdomen. As for every part of the treatment of ruptured AAA by endovascular mean, we have our algorithm for abdominal compartment syndrome. That means in case when we opening the abdomen, when we have to see if the bowels are at risk or severely swollen, we are going to use Bogota bag. That means we are going to put a plastic bag and above the bowel, so through this bag we can see the movement, we can see the vitality of the bowels. What is especially important in the cases when we use aortic balloon. Aortic balloon could cause ischemia, and we can very early detect the ischemia of the bowels to prevent the oozing which is coming from the abdomen. After decompression of the abdomen, we are using a VAC, and this is known as a Bogota VAC. If there is no swollen bowel and no bowel at risk, we will go to close the abdomen with VAC system and with Abra system, as it is shown here. As I mentioned at the beginning, it's obligatory what we are doing in our hospital according to our algorithm and our management of treatment of ruptured AAAs, that we are going for the post-operative CT angio. That means on this stage we can see if there is still bleeding from the excluded aneurysm, and in this case it could be the bleeding from the internal iliac artery, which is retrograde bleeding is still continuing, and this is continuing bleeding. So also after opening the abdomen for this continuing bleeding, if we could not treat endovascularly, of course, it is possible that we have to do some surgery. In this case, if there is a continuous bleeding, we are not going to remove the endoprothesis or to make open out of the iliac bifemoral graft. Then we are going just to use a pericardial patch and sew the pericardial patch on the hole. We started, as I told you, this is our experience from 1997 to 2014. In total, 145 open repair and 185 endovascular repairs. In 1997, we had almost 30 patients, and all were done with open surgery. With time, these 2 years, we started the first in 1998, when we did the 2 EVARs for the rupture case. With time, we had, by constant learning and strict adherence to our protocol, we came to the phase that we almost all the ruptured AAA are doing by endovascular mean. And as you can see, in last 6 years, from 74 ruptured AAA, we did 70 EVARs, and only 4 patients did by open surgery. This algorithm, this standard operating procedure, use all the adjuncts were the cause of our results. That means 30-day mortality is 14% in the EVA group. This is in agreement with world experience, and our results are one of the most successful results of the most successful treatment of ruptured AAA. After I told we have a protocol, we have a standard operating procedure, but we also have to educate ourselves. So we find it very seriously, and we are doing that seriously. That means we are starting with the medical school students during the lectures, then we are doing that with our residents, fellows, within the University Hospital Zurich, but also in Switzerland. We are doing that with ambulance, with the emergency doctor. We are informing GPs. That means all the people have to be informed about this. Our results and our management of algorithm resulted that we arranged some courses with European Society of Vascular Surgeons that where all key elements of treatment were presented within one workshop. During this workshop, as you can see, we are training the participants, we are training the fellows, the residents and young vascular surgeons on the flow model first, and thereafter we are doing that on the simulator. As you can see, this is really how it looks in the plastic model and how it is real deployment in a stent graft. Again, the basis for any implementation of treatment of ruptured AAA by endovascular mean is to have one protocol and to define the key elements. The key elements for success are hemodynamics, its imaging, its procedure, abdominal compartment syndrome, and its team. And we talked about hemodynamics, imaging, procedure, and abdominal compartment syndrome. But team is also part of all these 4 elements, and it's part of all our standard operating procedure for the aortic emergency. That means we have to see as a team how we are going to work in a shock room. We have to see how it's going to see if the patient is feasible for endovascular open surgery. In the operating theater, we are also doing as a team. In the decision making, should we open the abdomen, we have to collaborate vascular surgeon with anesthesiologists. Again, in imaging, vascular surgeon, interventional radiologists, technicians. Control the hemodynamics, we also have to work together. So the point is now the team, and this should be the second part of my talk today. That means for team training, why we need team training. When we are talking about team training, we have to say why it's important to perform team training. I told that the treatment of ruptured AAA is exactly the treatment of an elective case. Yes, it is, but it is in one very stressful environment. There is a very hemodynamics, very big hemodynamics disturbances, and abdominal compartment syndrome as main killer could occur in every moment. That means this is as elective case, but so many stressful hemodynamical disturbances. On the other hand, there is relatively rare entity. Rupture AAA is nowadays relatively rare, and this low volume can be compensated by procedure, rehearsal, pre and post EVAR. I want to give you some evidence why it is why it's so. What is also the important. That means that the teams who are working together differs. At the beginning, it was one vascular surgeon, one interventional radiologist. But with time, there is a lot of vascular surgeons, a lot of interventional radiologists, and they could not work together at the same time. So, as a point for this, we wanted to develop team training for emergent EVAR curriculum. That means we decided there is two. I put it some here to mention the people who are involved in this team training. This is the Everest group. This is a group who is dedicated to implement technical skills and to do a lot of simulation, and consists of the people from the University Hospital Zurich, from Imperial College London, from University Hospital Ghent, where it's working, just to mention some name, Isabel Farhezele, Mario Lascia, Colin Bicknell. These guys are involved in doing this team training. And then we decided, supported by Medtronic Academia. So Medtronic Academia offered us a platform to make a team training. We decided to do that in two places. The first place is we would like to perform technical and procedural knowledge and skills. This is something what was the normal course. To learn, all participants have to know what is technical and what is procedure for treatment of AAA. Then we trained a human factor skills and how to applicate technical and procedural skills in treatment of emergent EVAR. And this is the core slide. I would say, what does it mean? That means we have to make whole simulation. What, as a team, we have to do pre-admission, that is the story about telephone call, how to make the procedure, what everything to prepare for the procedure, to discuss before the procedure start exactly what we are going to do. That means all the team members would be together and discuss what we are going to do. Then we are going to the hybrid angio suite, or we are going to perform the procedure. Then we have to do it post-operative, how we are going to decide how to do it post-operatively, and finally to debrief. That means all this procedure represent exactly the real standard operating procedure in real life, but all this pathway is simulated. So this is the way how we think that we can improve the implementation of our intention to treat protocol to manage ruptured AAA. This is how it looked like in Imperial College, the first courses on team training, and this is how it looks like in a mixed reality. That means we can see here a patient. It's a simulated patient. This is patient simulated. He's on a table. He is the C-arm. There is a fluoroscopy screen. There is a control screen. So that is there is the people who are involved in operation. There is implanter, there is a radiographer, there is also the anesthesiology. So a lot scrub nurses, all the people are there who are involved in treatment of the normal real case. The whole simulation can take place in a simulated angio suite, but if these facilities are not available, they can also be set up in the real angio suite. That is what we call in situ simulation, making the use of existing facilities but simulated patient. That means this is a real operating theater, this is a real angio suite, but with Angio Mentor Dual X simulator and with instead of patient. The question is, can this simulator assist in training of team member? Yes, we can do this, and we can make like this. This is, once again, to repeat, this is a control panel. You're going to see that in a video clip where we can choose exactly all what we need, from the angiographic catheter, PTA balloon, then which prosthesis we want to take, then we can take which wire we are going to do this. That means through this we can practice only a generic cases that can be loaded on the simulator. That means one aneurysm which does not represent a real life aneurysm or any real life aneurysm. But we can also do patient specific rehearsal. That means this is the CT of the real patient, then it's to the software is transferred to the Angio Mentor simulator, and then we can simulate and we can practice all the procedure on the simulator. This is what is the future. That means that the specific CT angio data and procedure is rehearsed while the patient is prepared for emergent EVAR. That means we get pictures from a referral center, or we can our picture, so we will have time to rehearse that before we are preparing for the real procedure. So that was the first part of my talk based on our algorithm, standard operating procedure, and just to want to give you in proximity with team training and what is the real part of the team training.
Yeah, so thank you very much, Dr. Rancic, for this fascinating talk. I'm sure the audience had learned a lot today. I know I had. And now we're going to the second part of the webinar. So I would like to present a video demonstrating the endovascular treatment of ruptured AAA using our Angio Mentor simulator. And I would like to ask you, Dr. Rancic, if you can guide us through the procedure and explain what we're seeing.
Glad. I don't see it clear. Okay, much better. That means we are in the angio suite. This is Siam, this is patient. We can see the hemodynamic here, and now we can practice. This is Angio Mentor. This is 2 legs. This is like percutaneously accessed. This is 2 sheets. Now over the soft wire, we are going with catheter. Now we can practice technical skills. That means we have to learn and to show that we have how we can handle and we can manipulate with the wire and with the catheter. That means we are pushing the catheter, then we are going to with the wire. This is soft wire. We don't have to go too highway because according to the CT scan we can re-evaluate if there is a shaggy aorta, if there's a lot of calcification on thrombus, not go too high. Now we choose on this control panel exactly wire we need. We said here was super Steve wire Amplatzer, but we can take backup Lundqvist. We can take a Steve wire, and then over the catheter we are going to change the wire. Now we have a stiff wire. This is also what is a technical skills. We have to know that we can put a balloon just over the stiff wire. The scenario is that the patient crashed and we have to put a balloon. This is what I should tell you at the beginning. So that means we are going now with sheet. As you can see, the patient deteriorated. That means 973 systolic blood pressure. So we are using balloon catheter. That is only changing. We are using the same catheters, but just to have to remove for the angle. Then we have to inflate the balloon. And this is also what all the team training learned. The balloon had to be supported by a sheet. If it's not supported by sheet, movement of the balloon will push the catheter down and will result in non-efficiency of a balloon. Now, what we are going to do, that means we made a control of blood pressure. We stabilized patient with blood pressure 104, 108, and then we are going with the catheter over the soft wire. Again, soft wire, catheter, then a stiff wire, because we want to deploy endograph. We want to have to deploy the prosthesis. We are trying to pass with the wire, but it's not working. So what we are going now to change soft wire with stiff wire. Again, we in the model was chosen Amplatzer. And this is point. We have to deflate the balloon, and then we are going with stiff wire. When the stiff wire is above, at the level depends on the, then we are going to again to inflate balloon. And this is four-hand job. This is a teamwork. One person could not work this, and if the one person is not aware how it's technical, how is the procedure, and if they don't have mental rehearsal what they have to do, this is not possible to do this maneuver. So if someone wants to implement rupture, he has to use this simulator to learn how to use this. Now we are advancing the prosthesis over the stiff wire. Again, we are close to the blood pressure is 107. We are pushing that to the balloon. And now, as you see, the first angiography we are going to do in this case was at the moment when the prosthesis is below the renal arteries. If that means we are thinking on safety of the patients, we are thinking to not to give a lot of contrast. Balloon is up, it's supraceliac, and now we are going with another balloon. And this is also teamwork. This is also four hands work. That means we deflate the proximal balloon, but if inflate the distal balloon. Now distal balloon is below the renal artery. This is as the moving the clamp from supraciliac clamp to the suprarenal clamp. This is something what is the same from the open surgery. We are removing the balloon, the proximal balloon, and we have inflated the balloon into trunk of the endoprothesis. Now we are choosing the new catheter. This day we choose now multi-purpose because we want to cannulate the contralateral leg. Of course, there is no the same as the normal artery. There is some limitation of simulator, but the difficulties to cannulate the gate are the same as the exist in the real case. So we have to repeat it several times till we get this how to cannulate. Also, we can teach to use that with a sheet, and all these parts are part of our courses of our training, because once again, if someone wants to do a ruptured AAA by endovascular means, have to know have to have technical, procedural skills, and also non-technical skills. I think now it's going to work. Okay, it's working. Again, we are going with catheter, make the pigtail or make the headhunter or multi-purpose catheter that we are sure they are here. Again, we are deflating a little bit balloon, giving chance. We are choosing contralateral iliac limb. This is really a real life. And then we are going to put the contralateral limb. Before deploying the stent graft, we have to be sure that we will not cover the internal iliac artery. So the angiography showed us that internal iliac artery will not be covered. As you see, this is the internal hypogastric artery on the left side, so we are sure that we can safely deploy the stent graft. And this is what we are going to do it slowly. There is also different maneuver simulator is, for example, not giving us chance to push it or to deploy it in a way, but is giving us enough learning model and learning capacity to learn about technical procedural skills. Now, when we deploy the contralateral limb, aneurysm completely excluded, aneurysm completely sealed. Now we have time to remove a balloon. What is at the end of the procedure is, of course, to make angiography, and we can do that and see. That means we have to use a pigtail, and you see at the level of, and then you can see this, there is no endoleak, there is both renal arteries, and that was a superior mesenteric artery.
Okay, so thank you very much, Dr. Rancic, for your guidance and explanation. I think now we're ready for the third part of our presentation today, our webinar, and ask you some questions from the audience. So at the moment we have 2 questions. The first one from the audience, can you see clinical results improvements followed by patient-specific simulation usage?
Yeah, in general, we did it. As I told you, Everest Group did it, and we performed one randomized control trial when it was done in Ghent by Lisbeth Desberg. She completed her PhD studies. When she wanted to see the difference in the procedure in treatment of elective AAA in patients where it's done rehearsal before the procedure and without rehearsal before the procedure. And this is what is really advantage of this patient-specific rehearsal. It is not a generic model. This is a real case. This is a real patient, and this is real anatomy of the patient. That means if we have a simulator, we could try to perform the real operation as it is done in a real life. So we tried to we assess the technical factors of the procedure. So we were looking for the C-arm position, we look for the procedure time, we look for the fluoroscopy time, we look for the contrast volume, and we looked for the number of angiograms. What we find out from this study, from this randomized control study, we saw that the minor and major errors occurred less frequently in the patients with rehearsal patient-specific group. That means the number of angiogram to perform to visualize proximal on distal landing zone was significantly less in the patient-specific rehearsal group. That means this is some clinical value, and of these things are giving the one thing to be safe for the patient, to increase the patient safety, because we are giving less contrast, we are doing less angiogram, and the procedure per se is very efficient. It is interesting that we also saw how the people react during the procedure, and we see that the communication during the patient-specific, in the group, in the teams, because the study was conducted like this. Within 24 hours before the real procedure, the team procedure of the rehearsals, patient-specific rehearsal EVA was performed. That we saw the same group who did rehearsal did the real cases. The satisfaction of the people who did the rehearsal was more better, and they were feeling more comfortable doing the real case than the patient who than the team members who performed the procedure even without patient rehearsal. So that means this randomized study showed that error can be used in a different hospital settings by different teams with various EVA experience, and it reduces perioperative error and the number of angiograms to deploy the stent graft. So that means the procedure is faster, more precise, and I think this study, which should be published soon, is showing that should be some place for the patient-specific training.
Yeah, very nice. It will be very interesting to see the publication, definitely. Yeah. So second question from the audience, what is the added value obtained from simulation use in comparison to training without it?
Sorry, can you repeat once again?
So the question is, what is the added value obtained from simulation use in comparison to training without it? Sorry.
Yeah, this is the the problem, not the problem. What is good with simulation? This is a safe environment for every team member, for everyone. It was a lot of studies on carotid artery stenting, where was two groups, the novices and the experienced people, and the results were shown that also the novices can have a lot of profit, make a big profit from using the simulator and training. But also in this simulator setting, there could be novice and could be experienced guy, and we can go to all this part of the treatment. That means we can be focused on technical skill, we can be focused on the procedural skill, and we can be focused on the non-technical skills. So it is safer environment for someone who is doing the procedure, and this is also safe environment for the potential on the future patient, because there is no radiation, there is no contrast, and we can repeat the procedure how many times we need. Still, we feel satisfied, and we think that we understand the procedure. So before every simulation, start with mental rehearsal. That means we have to know exactly all the steps of the procedure. Then we are going to the angio suite and we do the procedure. So that means we are going, we can know, okay, I have to put a balloon. If I have to put a balloon, I need a stiff wire. If I need a long sheet should be 40 centimeters and should be 12 French. If we are not using like this, we can make a lot of errors. The second thing, before the simulation, all the members have to say what they have in the theater. This is something like safe surgery. That means we have to repeat exactly what we need for the procedure. We need a stiff wire, soft wire, balloon, for example, palmar stent graft. That means we need the parallel grafts for endodermal branching in case that something is going wrong. That means we have to have everything. So this is this mental rehearsal. Also, we can make also train that as a team, as individual, or the multidisciplinary. We can take making some distraction. We can additionally stress the team members during the simulation procedure. So we have to be aware also that technical errors occurred by most failures are largely caused by lack of communication and equipment related deficiencies. In a real simulation, we exactly know what we need for the operation. We repeated that before simulation, and we can practice everything. So with time we learn how should be the parallax, how should be the position of C-arm, how can we find the best angulation for proximal, distal gland, zone. So I think the simulation will improve a lot in treatment of simple cases, but more in the complex cases. You know, open surgery is a difficult. It's difficult after the procedure. It's very straightforward before the operation, but endovascular must be very good planned and could be a lot of peri-operative, peri-procedural errors. So simulation will help during the planning and during the perioperative to avoid perioperative procedures, because after endovascular treatment in general post-operative course is easier. So I see really the value of simulation in treatment of elective cases, but more in training of ruptured AAA.
Nice, thank you. I mean, I'm glad to see that we share the same thoughts about the role of simulation in training and planning of endovascular procedure. So at this point, it's time to conclude our webinar. And once again, thank you very much, Dr. Rancic, for your talk, and thank all of you for joining us today. Just to let you know, this webinar was recorded and will be available online in our website in the next couple of hours. Our next webinar is going to deal with structural heart disease, and of course we will give you all information about it in the near future. I hope it will be as interesting as the one we just had with Dr. Rancic, and of course we will update you with all the details in the next few weeks. We appreciate if you take a few moments to fill a short survey that will be shown right after we end this webinar. And with any questions that you have in regards to simulation, 3D printed models or 3D printing, we will be happy to assist, and you can contact us. Thank you very much, and goodbye.
Thank you from my side too.